Good morning, everyone. This is Dr. Somsekhar Nimbalkar, and I'll be speaking to you on developmentally supportive care for the neonate. I'm thankful to NNF Kerala for including me in this project for working with nurses and ensuring that we get some improved learnings on developmentally supportive care. I'm also thankful to Dr. Reshma and Dr. Deepen for sharing the workload with me for this particular module. So I'll go ahead and start sharing my PowerPoint straight away. Uh, yeah, so we're looking at developmentally supportive care for the neonate, and you can contact me at any of these emails or on Twitter if you want to get in touch with me. So I'll be discussing first a little bit of development of the brain, fetus, preterm, and later, a little bit of how vision develops, hearing develops, and the consequences of prematurity as to how they impact us. A little bit on NIDCAP, how to go about ensuring that neurodevelopmental damage is reduced. So let's talk about disability. Various follow-up studies of very low birth weight infants have reported that the incidence of disability to be around 15 to 25%. Uh, and when at school age, cognitive scores of previously very low birth weight infants were born, they are seen to be at least 10 points lower than similarly matched control children due to various difficulties with attention, behavior, visual motor integration, and as well as language performance. Important factors for this reason are gestational age, birth weight, sex, premature rupture of membranes, chorioamnitis, and brain white matter injury. So all of these things relate to the prevalence of disability in very low birth weight infants, or in other words, uh, most very low birth weight infants are actually premature infants. Uh, and as I said earlier, the intensive care environment and the family involvement in the intensive care can also affect neurodevelopmental outcome. Now, it is not just that just intensive care, but the involvement of family in the care of the neonate. When the neonate is in the NICU, that also does affect neurodevelopment, and we'll see how it happens. This is just an image from an imaging study which shows the synapses and the various neurons that happen in the brain. It is just a way to tell you that there are lots of synapses in the brain. Neurons connect to each other via synapses between an axon and dendrite. And most of the information that we know or what we remember is actually the reason because of the synapses. More the number of synapses that are formed, and more the amount of information that is passed through that, and memory is retained and maintained, and things remain. So the amount of synapses in the brain actually determine uh, how good we become and how we improve in many ways. uh, this is in general as to how uh, the brain develops. So there are various parts of development of the brain. This is what is called as cell multiplication. Then there is cell migration. There is cell migration. Let me just get the pointer through. Uh, yeah. So cell multiplication, there's cell migration, there's growth and differentiation, and there is angiogenesis and neurometabolism. Uh, the point I want to make by showing this chart is the formation of the brain involves a lot of things such as basically multiplication and formation of neurons. Then there's something called as a neuronal migration. The neurons migrate from one area of the brain in utero to another part of the brain. And then there is also glial migration or formation or supportive cells which actually enhance or ensure that this migration happens. There is electrical activity or synaptogenesis, as I mentioned earlier, and there is also something called as cell death which happens. So a lot of these things are happening in the brain in utero when the baby is inside the mother, and this happens continuously right from the time of conception till the time the baby is delivered. And actually many of these things continue even in the first 2 3 years of life for most of the things. So to give you an idea of what is happening, if you look on the screen, you see the brain at 21 weeks here, and you see the brain of a baby who's fully term, which is 40 weeks. As you know, you can easily see there are more sulci and gyri over here, and there are almost no sulci and gyri over here. And in between, you can see the sulci and gyri slowly increase. Now, what happens in because of the sulci and gyri actually ensure that the surface area of the brain increases. It also indicates that the more the sulci and gyri, there is more amount of neuronal mass and synapses that are happening. Now, for us as neonatologists, we need to understand that if you look at 26 weeks over here and 28 weeks over here and 30 weeks over here, look at the brain that is formed and look at the brain which happens at 40 weeks. Now, these are the babies who are often born at with this kind of a brain, 26 weeks, 27 weeks, and many of these babies, because of modern neonatal care, survive to become normal individuals. Okay, and this process is supposed to happen in utero, but this process happens after delivery or ex utero in the neonatal ICU. Uh, in other words, the brain develops much of the majority of the brain that develops in utero. And that development happens outside the mother's body if the baby is born preterm. This particular figure will tell you how much importance is the external environment, or how much importance is the NICU for development of the brain. In other words, what we do will affect the development of the brain. Okay. So there are this superlateral surfaces which show changes in size, profile, etc. This I have said earlier, and so I'll skip this slide as I mentioned it in my earlier slide. So these things continue. So from 6 months, so there are various parts of the brain which develop at different parts of time. Okay, it is also important to understand that many of the brain cells or neurons which develop also die a programmed cell death which happens. This programmed cell death is also important for a normal brain. So if the programmed cell death does not happen in the brain, in utero it normally happens, then we would have problems in development. Okay. So if you put up brain development in terms of from days to around to term, as you can see, there are various kinds of what do you say? These are the various parts of the brain. This is the ventricular area, and then there is a preplate, subventricular zone, intermediate zone, so on so till the surface of the brain, which is the pial surface. So this is the pial surface, and this is the ventricle, and this is the ependyma. As you can see, a lot of changes happen. You can see that these are the neuronal cells which are here close in the ependyma and close in the preplate. These all cells at the end of 40 weeks go to the outer side of the brain. So what is actually happening is neurons which are developed close to the ventricles migrate towards outside towards the surface of the brain. This migration is important and is a normal feature. And if there is an interference in migration, problems can happen. Okay, so next. Let's skip this. I've discussed this. This is just to say that migration happens because of supportive cells, and if migration does not happen properly, then we could have problems. And it's a complex process, which is all kind of pre-decided and depends upon a lot of uh, chemicals that are produced within the brain as a part of the normal developmental process. Okay. So as grossly, if you look at the term baby's brain, it is around 300 to 400 gram in weight. Depending upon the weight of the baby, you can have a 2.6 kg full-term baby, vis-a-vis a 4 kg full-term baby. And the weights of the brain can depending upon the weight of the baby, would obviously vary. So on an average, 350 grams is the weight of a term newborn. Neonatal males are slightly higher than heavier than those of females. As you would know, and there's a slight difference between weight of males and females at if you take the averages. Uh, the head is large at birth, and it measures around 1/4 of the total body length. So if you the body length of a newborn is around 50 centimeters. 12.5 centimeters would be the length of the head. But as we grow, the length of the head in terms of the total height is relatively less. So in other words, the brain occupies a large amount of space or contributes to a large amount of weight for a newborn. And in many ways, because it contributes a large amount of space as well as weight in a newborn, it will also utilize more energy in a newborn as compared to maybe an adult. Okay. So the volume of the brain is around 25% of its volume in adult life. So if you consider newborn finger, and look at the size of a newborn finger, and you can look at the finger that one has today. On the newborn finger or any other skeletal part would be much less, maybe 10, 12, 15% of the adult part, body part. But the brain occupies a much larger body part as compared to the rest of the organs. And most of this increase occurs in the first year, at the end of which uh, the brain goes from 25% of the adult volume to 75% of the adult volume. This also indicates that the brain, though it's a large part of the body at birth, it continues to grow in the first 2 years of life and mainly in the first year of life. And growth occurs because of various reasons, by the size of the cells or by the increase in the number of cells, and or by the dimensions of dendritic trees, etc. Growth also happens because of myelination. The axons, the neuron has a dendrite, the body of the neuron, and the axon. The axon gets myelinated by supporting cells, and this myelination occurs throughout. Actually, it can go on for a long period of time, but majority of myelination begins after birth and continues to go up till 2 years of life and even further. Uh, During the second and subsequent years, as I said earlier, growth proceeds much more slowly, and brain reaches around 90% of the size by the fifth year of life and 95% by the 10 years of life. Now, why is this important? Because when a baby is born preterm, the brain size will obviously be less. It will be less developed, as we saw in the pictures earlier, and the brain has to grow to this particular size by fifth year or 10th year. And we do not know how much we do know, but we whatever we do in the neonatal ICU can impact the growth of brain further down the line. So whatever therapies we give, whatever we do in the ICU can impact the growth of the brain. Hence, whenever we evaluate any therapy in neonatology, we always look at the outcomes of those children at 5 years and 10 years or in adolescent, to see what we did in the neonatal period. Has it impacted or has it influenced the growth of the child at 5 years and 10 years? So no, unlike pediatrics or adults, what treatment you give will show some efficiency within a week, within a 10 days, and you can declare a patient to be maybe cancer-free at 2 years or cancer-free at 5 years. But in case of neonates, you have to follow them up for 5, 10 years to find out whether whatever you did in the neonatal period, was it really effective or not. Uh, this is another little complicated thing to show you how the various parts of the brain. So these are various parts of the brain and how they progress from the preterm period to around 2 years of life. So this is what is called as the timeline of white matter development. Uh, this picture is mainly to show that a lot of things are going on in the brain when the baby is born, and a lot of this continue to grow. These changes continue throughout the neonatal period and even into the first or second year of life. What it means to us is, because a lot of these things are happening in the brain at the time the baby is born, what we do can impact or harm these processes in many ways. So there are these various processes like induction of ectoderm, formation of neural tube, neural migration I talked about, programmed neuronal death, which happens, generation of axons and neurons, synaptogenesis, or the connections between neurons and axons, uh, elimination and stabilization of synapses, angiogenesis, which is blood vessel formation in around the vessels, and gliogenesis, or the supportive tissue, and the myelination of the axons. A lot of these processes are happening at various points of time. Uh, so 70% of the neurons in the human cortex in the brain undergo apoptosis, or what I said earlier is programmed cell death between the 28th week of gestation and term. So understand that whenever we see babies who are born preterm at 26 weeks, 27 weeks, or 28 weeks, if they were in utero, a lot of these neurons would have gone programmed cell death. By being born preterm and by giving them a lot of therapy that we give in the NICU, a lot of these processes can be disrupted, and that can cause an issue. Synaptogenesis, or the connections between the axons and dendrons, where most of our processes are stored, does happen along with the growth of dendrites and axonal arbors. The volume or the size of the gray matter increases fourfold from the 30th to the 40th week of gestation. So that's a tremendous amount of increase of size of the brain. And the gray matter is actually what defines cognition or intelligence. The white matter is generally the transmission of data from one part of the brain to another part of the brain, but the gray matter is where everything is stored, or what we uh, think or what we do happens in the gray matter. And this increases from the 30th week to the 40th week of gestation. So in an animal model, 40,000 new synapses are formed every second in the visual cortex alone. Now, the reason I'm talking about this is because this is where information is stored, this is where memory is stored, this is where things happen. So connections between axons and neurons happen at a very rapid pace. A large number happen every second. So just imagine in a day how many synapses would be forming. Of course, at the same time, many synapses are getting dissolved, but the rate of formation of synapses, a high rate of formation of synapses is an indication that the brain is doing well. Now, why is it important? Because any kind of things that we do in the neonatal period or any kind of insults that the baby suffers can cause a problem in the synapses. It has been seen that if the baby suffers from pain, okay, or the baby suffers from hypoxia or any other insults to the brain, then the formation of new synapses is prevented, or dissolution of old synapses is prevented. So this synapse formation is disrupted whenever there is an insult to the brain, and this insults to the brain can happen because of hypoxia, can happen because of say pain, can happen because of drugs that we give to the patients, and so on and so forth. So we often do not know as to what damage we might be doing to the baby if we are not because it is born preterm and we are giving therapy which we may not know much about. As I said earlier, the parental involvement is important. Synapse formation is directly linked to whether the parents interact with the child or not, and hence kangaroo mother care, etc., plays an important role in ensuring that this development is normal. Okay, so coming to the next, wiring of the neural circuits is regulated by endogenous factors as well as by sensory input and experience. Now, it is important here when I say sensory input, it means vision of the baby, it means sounds that the baby hears, it means the smell the baby gets, and so on and so forth. The touch the baby gets, and how often that happens, and whether that sensory input experience is pleasant or not pleasant. And just to give an example, the sound of some things, papers moving on the warmer, or some screeching sounds because the chair is moved in the NICU is not very pleasant even for us, and it is not going to be pleasant for the baby. But if the baby hears the mother's heartbeat, that is going to be pleasant for the baby. So this kind of sensory input, whether it is pleasant or not pleasant, does make a difference to the development of the brain. So it has been shown that even in 8-year-old children, that babies who are born preterm have had regional reductions in brain volume. So we do know that prematurity has an effect on the brain. As I said earlier, pain during neonatal period has long-lasting enhancement of stress responses. Means whatever pain I'm feeling today, if I was a 5-year-old or 8-year-old, if I felt pain to say 1x extent, being born premature and subjected to pain can increase the pain at 5 years for me by 2x or 3x. So there can be enhancement of stress responses, as I said, altered neural circuits. And one of the things that I was discussing earlier was that the rates of CP might be the same, or people might feel it is gone down, but the number of people who are left with learning deficits and behavioral changes because of being born premature and not subjected to proper or neurodevelopmental therapy or supportive care can be relatively higher. So we should try and do as much as possible uh, well care for the baby so that it does not have a lot of learning deficits or behavioral changes. Variations in maternal care have been shown to promote synaptogenesis, learning, and memory. What it means is the mother needs to be involved. There are a lot of studies, even in animals, which show that simple touching of the rat pup by the mother or simple patting the rat pup by the mother does improve even genetic expression in the baby. So a lot of this involvement of the parents in neonatal care is very important and does affect the premature brain. This is to show a gestational age by specific, what do you say, improvement in neonatal care. If you can see over the period of years, there has been a growth in the number of people that are surviving. If you see at the lower end of the spectrum, 24 and 23 weeks, more number of babies are surviving now than did earlier. And this is going to be the same in India. This is not Indian data, but what will happen over the years as we get more and more better with neonatal care, more and more sicker and smaller babies will survive, and it is our responsibility to ensure that these babies have an intact survival. There is increased survival of earlier born and sicker infants worldwide. Uh, Major sensory and cognitive, communication, motor, and neurodevelopmental sequelae will continue to occur, because many of them earlier 24 or 25 weeker or 26 weeker would not survive in India, maybe 20 years back. But today that baby will survive in a lot of good units. Many babies will survive, but many of them will survive with at least some amount of cognitive sequelae or communication sequelae. Many health issues such as attention deficit or other ADHD, anxiety disorders, etc., or difficulty in emotion regulation can be traced back to the neonatal period. And infants with lower gestational ages or preterm babies have shown crying, eating, and sleeping problems, which indicate early regulatory disorders. And it is very important to understand that occurrence of these regulatory difficulties in the first few months of life can be predictive of later cognitive and behavioral challenges in during schooling or preschooling time. So in other ways, what we think like are physiological issues such as eating or sleeping or crying, etc., in the infant age group in the first 6 months of life, and many of this might happen because of babies being born premature and not received appropriate care. These are predictive of what will happen later on in life, and in other words, indicates what kind of an adult life that particular person will live. Okay, so there is plenty of evidence of early and painful events, procedural events on adverse brain development. Greater exposure to stressful procedures such as causing pain uh, has been shown to be associated with reduced brain size and in the frontal and parietal regions in preterm neonates when assessed at term equivalent age. So there is all this brain microstructure and functional connectivity which changes. And let's go to the next one. Early exposure to stress can affect the functional maturation of limbic circuits. And limbic circuits are where emotion and pain, etc., is experienced. And whether we like it or not, most of us humans respond with emotion to many things in life. It's the same in babies. And if the emotional area of the brain is not very well formed or it is malfunctioning, then that particular individual, when he grows up to be an adult, will have difficult responses, will be having issues when expressing emotions, etc., and which can cause a lot of social issues later on in life. Increased somatization or pain at age of 4 to 5 years is seen in babies born preterm or babies born low birth weight compared with full-term born children. So in general, what I want to stress is having pain or having stress or having improper growth in the NICU does have long-term consequences. Okay. So what are the various factors that increase the risk of brain injury in a preterm infant? So there can be cerebral factors, there can be respiratory factors, and we see all this in the NICU. Hypoxia, hypercarbia, pneumothorax, hypertension, hypotension, okay, infections in the baby, chorioamnitis, acidosis. So all of these things that you see on the screen do happen in preterm babies, and all of this can increase the risk of brain injury. What can decrease? So we can do a lot of things in the NICU, and this is not really this is not generally thought of as developmentally supportive care. If you look at the slide, it will tell you about mean airway pressure and PaCO2 and synchronous mechanical ventilation. The point what I want to make is whenever we do even things that we don't think of as developmentally supportive care, many of the actual therapies that we give, such as gentle ventilation, etc., or even steroids or giving antenatal corticosteroids or not giving postnatal steroids or reducing postnatal steroids or using caffeine for apnea of prematurity. All of these interventions that we do in the neonatal period do ensure that the baby's brain develops normally or with minimal deficit later on in adult life. So a lot of these things can reduce the chance of brain injury in a preterm infant. Commonly what we do is oxygen saturation, and while we keep oxygen saturation limits on the higher side nowadays as compared to maybe a decade or 2 decades earlier, we see that a lot of people are not, it is not possible to maintain the limits most of the time. There can be alarm fatigue because a lot of alarms are buzzing and your attention is drawn to too many alarms. And so it is important to ensure that we work in the NICU and try and reduce the alarm fatigue and try and ensure that the baby gets proper oxygenation throughout its stay in the NICU. So we should not over oxygenate and we should not under oxygenate. Over oxygenation tends to cause retinopathy prematurity significantly, but can also cause many other diseases in other organs. And under oxygenation has been seen to lead to more deaths. The chances of death in the neonates increase. So coming to giving you a background as to what how the brain develops and why it is important to ensure that the brain develop properly in the NICU. What are the long term? Because what we do in the NICU, what we do in the neonatal period, has an impact for the baby in the long term and into its adult life. So the 1 month or the 1.5 month or the 2 months that the baby might spend in the NICU, and if cared for well, can give really good inputs for a healthy adult life. But if we don't take good care enough, the baby survives, and then that baby might survive with deficits. May not be CP, as we are not doing that badly as far as CP is concerned, but there might be issues such as poor learning or behavioral disorders or emotional disorders, which can cause problems in managing this kind of children, and might find it difficult for them to integrate with society in the longer run. So what is developmental supportive care? It is has been defined in 2004 as that are practices implemented by, if you see, neonatal nurses to reduce stressful external stimuli such as noise and light levels, and to provide secure boundaries by containing preterm infants in a flex position that optimizes postural development. So if you look at the definition, it's really up to the nurses to provide developmental supportive care. But as I said earlier in the previous few slides, a lot of therapy that we do and whatever we do in the NICU is in many ways developmentally supportive, but generally may not be thought as developmentally supportive care. So the physical portion of what we do in the NICU in terms of positioning the baby, decreasing the light, decreasing the sound, okay, ensuring baby gets painless or less painful interventions, clustering of care. All of these generally constitute what is called as developmentally supportive care, and it does improve the development of the child. But apart from that, what kind of ventilation we give, what kind of drugs we give, okay, what kind of antibiotics we give, all of those things also can impact the development of the baby. So just as I said earlier, positioning, we will discuss this in detail, but generally we want to have the infant in a contained flex position with firm boundaries, with a neutral neck and shoulders protracted. Skin to skin care is actually part of developmental supportive care. It has generally not thought of as developmental supportive care, but more and more it is actually replacing NIDCAP, because NIDCAP is more like a structured program, while KMC is also a structured program, but KMC is relatively much more easier to do. It requires relatively less training, and it is generally probably liked more by the mothers. Okay, so even holding the baby whenever procedures are made, and holding it in a relaxed way, singing to the baby when procedures are done, all these things are pretty important. Clustering of care to ensure that there is periods of rest between whatever procedures are carried out. Non-pharmacologic pain management as well as pharmacologic pain management can improve and does improve the development of the baby. Cycling light and dark periods, decreasing noise levels, so environmental management, and cue-based feeding is also a part of caregiving. Generally, when we talk about developmentally supportive care, people think about positioning, noise, sound, then the little bit of pain management, and then also kangaroo mother care. So this is the basic principle. So ensuring that there are boundaries for the baby, we'll see in a picture later on. The arms and knees flex or side lying with hands in midline. Always move infant slowly during position changes and contain limbs to avoid a startle response. So what it tries to mean is when you are doing maybe a change in the bed or moving the baby, it is important to ensure that the limbs are not left alone, and there should not be any sudden changes in posture. Because if you do either of these two, then there's a startle response and the baby goes into a stress reaction. okay, and avoid hyperextending either neck or the arms, and basically try and maintain a fetal position as much as possible whenever possible. Okay, ensure that there is clustering of care, as I said earlier, and try and give care when the baby is awake rather than according to a fixed schedule. It can be difficult to know when the baby is awake, but if you find that the baby's heart rate is on the lower side, normal lower side, baby is sleeping and having a rhythmic breathing, it might be better to put off the bilirubin measurement maybe half an hour later or 1 hour later, or better to so it's better to move it a little bit later rather than at that point of time, because what happens is in an ICU when there are lots of patients, we want to try and finish off our work in a particular time. In a hurry to finish our work, we end up disturbing a lot of babies. So I think that needs to be uh, thought about when we are taking care of babies. Uh, so it's important. So there are various stages in which the infant goes. So there can be quite awake stage, quite alert, or quite sleep stage. So it's important to wake up the baby, or maybe ensure that the baby is in a quite alert stage by talking in a soft voice and touching the infant gently before handling the baby. So you don't just go to a sleeping baby, pick it up and move it around. So you need to spend some time to ensure that the baby state changes before you do any action. Reduce environmental noise in the unit. We'll come to that later. Quiet time also will come to that later. And how to cover the incubator to reduce the bright lights also we'll talk about it in detail in some time. If the babies are term bigger, and it's more easier to dress and bundle the infant. So the limbs, if they're left free, and the limbs move, and then the baby can and does do get started. So the NIDCAP, as I was discussing yesterday, it's something which began a long time back, and it's newborn individualized developmental care and assessment program. So it's a program. It has a particular teaching pattern. There is training for NIDCAP, and so this is something which began a long time back. It was also, I think, in a way, it requires people to get trained in NIDCAP, and then begin and use NIDCAP in your nursery. So the process of getting trained in NIDCAP, etc., does have a cost. Okay, and because it has a cost and there are few trainers that are available, it can be an issue. So it is possible that you can look at the literature and develop something similar to NIDCAP and utilize it, but that would not be really called NIDCAP. So NIDCAP is something which has been used by a lot of people, but as far as my understanding goes in India, a lot of people, kangaroo mother care is a much better option, and you have already had a lecture on kangaroo mother care, and that's a easier, better, and simpler option with a lot of support from the government of India and the professional societies of doctors and nurses in India. NIDCAP, coming to NIDCAP, it's based on something called as a synaptic theory, to look at simultaneous maturation and interplay between the different subsystems of behavior throughout development. So there are various sensory systems that develop at different types, and it looks at integrating all of this together to provide developmental care. So this is, if you look at the parts of the brain, we have the autonomic part of the brain, the motor, and then this thing looks at the interaction between the environment and self-regulation of the baby, and what is the attention and interaction, and overall the sleep-wake cycle. It is important to understand that babies in an NICU really do not get continuous sleep at any point of time. If the baby is on an incubator or a warmer in a relatively uh, chaotic nursery, or in a relatively noisy nursery, or with bright lights, etc., babies hardly get less than a 1 minute of continuous proper sleep. Okay, less than. So you may think that the baby is sleeping, but the baby is actually not having good quiet sleep. If you compare this sleep as compared to when you give kangaroo mother care, babies tend to sleep immediately, and then they tend to sleep for 1 hour at a time. The sleep cycle of a preterm baby is roughly 55 minutes, and that is the reason why whenever you give kangaroo mother care, you should try and attempt to give at least 1.5 hours of kangaroo mother care. The reason for 1.5 hours is, by the time you begin the step of kangaroo mother care, and by the time you end the process of kangaroo mother care, if you take this entire time to be 1.5 hours, then we can ensure that the baby is in the kangaroo position for at least 1 hour, which is enough to complete a sleep cycle. Okay, and the sleep cycle is very important to ensure development of the brain. So NIDCAP has been endorsed by research from various scientific fields, including neuroscience and psychology, medicine, and nursing. It looks at the various subsystems that I mentioned earlier. So it looks at autonomic, motor, the state regulatory or state organizational. So uh, what state the baby is, whether it's active, quiet, or in a crying state, and the attention interaction and the self-regulatory system. So it basically looks at modulating and the smoothness and regulation between these various five subsystems. uh, Repeated formalized. So it's the importance of formalized is the reason why we require training. Naturalistic observation of the infant before, during, and after carrying procedures for feeding, collection of blood samples, etc. So feeding, you remember, is also a procedure. Look at whether the baby is regulating. We'll come to how we can make out whether the baby is self-regulating as revealed by the approach or avoidance behavior. So there are behavioral cues which can tell you whether the baby is self-regulating or not. And as I said, specialized workshops and trainings are required, and we have to continually adjust the care that we give based on the maturity of the baby at that point of time in the NICU. So 28-week-old will get a different kind of approach as compared to a 32-week-old as compared to a 36-week-old, and that approach has to be individualized. So hence, it is not the same for all the preterm babies. Uh, so in introduction of NIDCAP involves a considerable investment at all levels of organization. So this is what I was talking about in terms of funding that is required to ensure a good NIDCAP program. It requires also some physical changes in the NICU as well as substantial educational efforts and changes in the practice of care. And while in the West, where resources are widely available, and NetCap has been a success, but I don't know of many NISUs in India where they use NetCap on a regular basis. The concept is understood, how the basis of NetCap is understood by most of us, but I don't think any of us actually participate in a formal training program of NetCap. So it is attractive from an ethical point of view. Uh, so as far as I look at developmentally supportive care, NetCap is a very good thing, but because it is resource intensive and requires training, etc., I would rather go with kangaroo mother care, which is more widely available, which is supported by the government of India and various professional organizations of India, such as IAP, NNF, and as well as nursing associations of India. So this is a review which is kind of a what do you say, a dampener on NIDCAP. This review in 2013 did not find any evidence that NIDCAP improves long-term neurodevelopmental or short-term medical outcomes. Now, this is despite the amount of training and etc. that goes into NIDCAP. As opposed to this, if you look at kangaroo mother care, there is loads of evidence which show that kangaroo mother care improves development. In fact, in a paper published in 2016 in pediatrics only, it was shown that adolescents who received kangaroo mother care had much more, as preterms, had much better development than those preterms who did not receive kangaroo mother care. So the evidence for kangaroo mother care is extensive, and it is actively promoted by the World Health Organization. Coming to the environment, we discussed earlier, and as to the environment of the newborns influences the development. This includes light, sound, temperature, activity, and space. Light and sound is given a lot of importance. We don't talk too much about temperature or activity. Uh, it is important to ensure that there is a good environmental modification for infants to have ready access to their familiar and unique mothers and fathers who are able to provide a consistent, intimate, and regulatory secure base for development. In other words, the participation of the parents in the care of the baby, newborn baby, is actually a very good way of providing developmentally supportive care. So, what the parents can do, such as feeding the baby for little bigger babies, giving kangaroo mother care, ensuring that they are giving some kind of holding the baby when a painful procedure is being done, or many such things. So, whenever you try and involve the parents, the benefits on developmental care are extensive. Design NICU design standards are important. Uh, if you want to really give good developmental supportive care to the newborns in the NICU, the NICU has to be built in such a way that many of these factors are considered right at the time of building and not later on when you go and try and modify an NICU. Unfortunately, in India, that is the way we work because of resource constraints, space constraints, and the model of healthcare that we use. We do not have a lot of chance to ensure environmental design to improve developmental supportive care. Okay, what can change? Touch, kinesthetic or proprioception, how the baby is placed, movements of the baby, smell and taste, and vision. There's a rapid maturation of each sensory system. So each of these sensory systems matures rapidly, and we saw how the brain develops from 28 weeks to 40 weeks. Uh, if many of these can develop at different rates, though they develop in utero. In utero, what is happening? The baby is in a secure space. The baby is moving on its own. Baby hears various sounds. So all of this, like the kinesthetic and the vestibular processes, can develop normally in utero. But then when the baby comes out at 26 or 27 weeks, baby does not get the same kind of movement that it is getting in utero. Okay, baby is not hearing the same sounds that it is hearing in utero, and so and because of the environmental change, there is a difference. Baby is getting a lot of vision. So in utero, the vision, the uterus is dark and does not get so much of light on its retina or its eyes. But the baby is born at 28 weeks and 29 weeks, and in the NICU with lots of light because you want to see how the baby is doing. This vision development can happens at a faster rate because it is exposed to light, while the kinesthetic development may not happen because the baby is not moving so much. So all of these things we should understand does influence the development of the brain. So maturation of the hearing in the fetus is more intense during the specific time that vision is not developing and is not being stimulated by light. So as I said earlier, when the baby is in utero, the hearing is developing faster than the light. But when the baby is born at 28 weeks, baby gets exposed to both sound as well as light, and hence the differential development that is supposed to happen in utero is not happening in actual when the baby is out. So the rates of development, so the timing of development actually changes. Okay, and so the baby has to adapt to it. And so if one system is stimulated more, and then because it is stimulated more, it develops out of sequence to the general sequence of development. It can interfere with the development of the currently emerging system. What I mean is, if hearing is supposed to develop earlier on and vision is supposed to develop later on, if the baby is born preterm, vision also begins to start developing simultaneously as the time as the hearing is developing. So the development of one can actually interfere with the development of the other, and in ways that we do not know. Okay, so inappropriate visual activation during the stage of development of hearing will not only alter the hearing but will also affect vision. In what way? But it does. What I want to bring out, it does definitely change in the way the baby improves. Sensory input introduced to the growing organism before the sequence is ready also will interfere with the organism's development of perpetual and behavioral development. So as I said earlier, introducing something else in addition can change the way in which the baby's brain develops. Uh, this can occur across early development across all senses. So normally what happens is tactile first, vestibular, chemical, auditory, and visual. So that is the sequence of development that we expect for a normal baby which is born at term. Okay, limited and regulated patterns of sensory stimulation associated with prenatal development is disturbed completely by preterm birth. So preterm birth, as we all know, received dramatically altered amounts, type, and timing of sensory stimulation. So the stimulation, the baby gets a lot more stimulation than it should have got. Okay, so it gets a lot of visual stimulation, it gets a lot of auditory stimulation when its vestibular stimulation may not have been as well developed. So the brain has to kind of deal with all of this in different ways. Uh, so this is, if you look at what happens on the left hand side, there is a development of sensory pathways during gestation, and on the right hand side there is exposure of sensory pathways to the NICU environment. As you can see here, this tactile, vestibular, olfactory, gustatory, auditory, and visual. But once the baby is in the NICU, what starts fast and similar is auditory and visual get stimulated first, then followed by tactile and vestibular and olfactory and gustatory. So because there is continuous exposure to auditory and visual and minimal exposure to movement, as I said earlier, baby they are lying on the in the radiant warmer or in the incubator, and there is not much vestibular development. While here in gestation, the baby is moving constantly, and hence the vestibular system develops faster. So because this differential rate of development of various systems occurs, uh, uh, we need to understand that this is happening. And so if you begin kangaroo mother care earlier, so if you begin as early as possible, not only when the baby is stable, but the baby is born. If you bring the tactile stimulation over here, then you are at least ensuring that the baby gets tactile stimulation. And the more amount of kangaroo mother care that you give, it ensures that there is continuous tactile stimulation for the baby. By ensuring kangaroo mother care, you are also ensuring that the smell of the mother is got to the baby. So all of these things kind of, and ensuring breastfeeding ensures gustatory. So all of these three things will come and move over here. Okay, if you start beginning kangaroo mother care earlier. Vestibular. Now, how does vestibular change? Now, if the baby gets kangaroo mother care as early as possible, and as it is often expounded, if we give skin to skin care and the mother is moving all the time while giving skin to skin care, baby is secure on the chest and the mother moves. That also ensures that the vestibular system of the baby is stimulated while the baby is held in a secure position by the mother. So, this is important for us to understand the role kangaroo mother care plays in development of the baby. Okay. So I think we have already discussed this. The tactile and vestibular stimulation, which is there, reduces, and more auditory and visual stimulation. And as I said, these changes in that impact the baby are not well understood. Uh, but this can have long-lasting effects on the developing premature brain. Okay. Uh, so this has been already described. Now, coming to the line about neural plasticity. What I mean by neural plasticity is the brain actually can respond in various ways. Okay, and while our actions can damage the brain also is able to respond in such a way that it tries and maintains normality as much as possible. You would be surprised to know that recent research shows that a person who's blind from birth for whatever reason, but the brain of the person is normal, but there's something wrong with the eyes, etc., and hence the person is blind from birth, can actually be made to see by having a sensory system in the tongue. So you can put something in the tongue which is connected uh, to the head, and that person can actually see. There are people with half a brain uh, where one part of the brain is not at all there. Those people can actually uh, walk. When we know that one part of the brain controls the other part of the brain, if one brain is not there, you cannot walk on the other part of the limb. The other contralateral leg and hand cannot move. Uh, but there are people like that who can actually move, and we really don't know why, but that is because of neural plasticity. So you can go and search for neural plasticity of a woman with half a brain, and you will realize how powerful the brain can be. So neural plasticity, in other ways, allows sensory experience during early development to leave lasting and functional changes. And we can, so what it allows us to do is to influence the brain positively in many ways. Neural plasticity should be taken of advantage by us, uh, people working in the NICU, to ensure that the development goes ahead in a proper fashion. There's something called as the intersensory redundancy hypothesis, which talks about the same information being available through two or more senses, and we looks at which sense is given more attention to. I will skip these slides, but um, just to say that the brain is a complex organ, and the ways in which it develops is not really well known, and we have to try and keep on understanding, improve our understanding over a period of time. So this does not allow preterm infants to experience stimulation in one modality concurrently with stimulation in other sensory modalities. Uh, so one way is sound sources are not visible to the infant even if the infant is turned towards them. So when I know that I'm looking something at which is making sound, my brain makes a connect between what is making the sound and from where the sound is coming. Now in the NICU, this is not happening and the brain does get confused. Uh, so respiratory and monitoring equipment sound uh, happens independently to other sensory modalities, and they do not provide any opportunity for the neonate to make a connect with why that sound is happening. So this is important for the neonate. And integration of multiple senses is associated with the development of intellectual abilities in school-age children. What it means is the ability of the brain to connect information received uh, from various senses and to connect them and to understand that this is coming from one particular source uh, allows them to develop in an intellectual fashion. In other words, the cognition is improved if they can make a connect between multiple sensory sources of information and that single source which is providing that multiple information. For example, a mother who's giving Kangaroo mother care is providing tactile stimulus, is providing the sense of smell, is probably singing and providing auditory input, and the baby can actually also see the mother early on. So the baby makes a connect with the mother, and it allows for sensory integration in the baby's brain. But if the baby is lying on the warmer and there's sound coming from a saturation monitor, or there's some other sound coming from a file being moved, the baby cannot make those connections and does not understand, and that can leave the neurons confused. So visual development does happen, as somebody said yesterday, that before 32 weeks or so, and they have thin eyelids and little or no pupillary constriction, and this allows little ability to limit light reaching the retina. By 34 to 36 weeks, the pupillary constriction is more consistent and the eyelids are thicker, and so this kind of allows limited light to reach the retina. There is no developed pathway for an image to reach the visual cortex in utero because the baby is in a dark place and the fetus in utero has no exposure to light or visual image. So understand this, that the development of the vision starts and happens without exposure to light and in utero. But if the same baby is born preterm, that development of vision has to occur while there is almost continuous exposure to light when the baby is born preterm. So that development is going to differ and cause issues. Uh, so the pathways from the retina to the visual cortex that transmit visual images become functional at around 39 to 40 weeks of gestation. So the nerves which go from the eye to the brain are actually very functional only when the baby is term. So when the baby is born preterm, all these things are not very well developed. And just because the baby is born preterm, it does not ensure that the visual system maturation is accelerated. So what is supposed to happen in 12 weeks will not happen in 2 weeks. It will again take 12 weeks, probably more because of interference with the that the light gives to the retina. So there are various five major cell types and layers. There are some cells which are not seen earlier. And so the retina is a very complex structure. It is hidden from light for most parts in utero, but when it is exposed to light, many of these cells may not be able to function in a proper fashion. So again, if you look at this, there are various kinds of cells in the retina, and all of these cells appear at different points of time. So this is 20 weeks estimate, and this is 40 weeks estimate. And a lot of this, so the color ones come earlier, while the black and white comes later, and so on and so forth. So it's important to understand that a premature baby has a lot of organs that are not well developed. It's just not the lungs which are not well developed. It's not the brain which is not well developed. Every part of the baby is not very well developed, and the earlier birth will cause a disruption or will influence the development of every organ that is there. And currently we're talking about the vision apparatus. So there are various processes. I'll go faster. There are genetic and epigenetic processes. There's endogenous brain activity, and there is also exogenous neurosensory stimulation. Uh, as I showed you earlier, the limbic system is one which develops earlier, followed by the hippocampus. So emotion and feeling develops in that region of the brain develops in the fetus earlier. A little later on hippocampus, uh, then later on chemosensory, which is olfactory or gustatory, which I showed you in a slide earlier. Then somatosensory, which is touch, pressure, vibration, temperature, and pain. Then kinesthetic, complete development would occur, auditory hearing, and then visual vision. Okay, so vision probably is one of the last sensory systems to develop in a baby. So because of various activity dependent processes that are there in visual development, this become extremely vulnerable to the events in the NICU. So we have a responsibility to ensure that we are able to protect REM sleep and dark periods, or rapid eye movement sleep and dark periods. And KMC is seen to increase REM sleep. We have to try and ensure eliminate direct light exposure to infant eyes and use indirect light whenever possible. Limit intense noise and other unnecessary competing sensory stimulation. Be careful, give careful attention to the sensory environment of each infant in the NICU. Okay, for a good healthy visual development, it requires light on the objects and not direct light in the eye. Focus, attention, try and prevent novelty or change. It would require movements. It also requires color. And what are the factors which interfere with external visual activity? Intense direct light, that can be from the overhead part of the warmer, lack of objects and patterns in focus, lack of attention. So more sedation would cause disruption in visual activity, lack of change in the environment or habituation and lack of interest, lack of movement, and total darkness or absence of adequate light when awake. So if you can look at this, a lot of these things can be changed actively by the health personnel working in the NICU. And it changes from gestation to gestation. So let's look at VLBW babies between 22 to 28 weeks of gestation. What is important here? It is important to protect the eyes from direct light and keeping ambient light exposure to low levels. Okay, so this is for 22 to 28 weeks. Important to limit exposure to drugs that can depress the endogenous firing of cells involved in early visual development. For 20 to 36 weeks, protect eyes from direct light exposure and maintain low levels of ambient light. Provide some daily exposure to light, preferably shorter wavelengths for ensuring entrainment of circadian rhythm. Again, protect sleep cycles, especially REM sleeps, and avoiding sleep interruptions, bright lights, loud noises, etc. Avoid high doses of sedative and depressing drugs, which can interfere with various cells waves that happen. And these are important for visual system development. Provide developmental care appropriate for the age and maturation of infants. Beyond 36 to 39 weeks, remember 39 to 40 weeks is when actually the vision system is supposed to develop completely well, with the nerves transmitting information from the retina of the eye to the occipital cortex. The cortex requires visual experience in humans for development of directional columns, and hence this is the point of time when it needs active visual stimuli. Social and emotional context and atmosphere matter as much as visual experience. So it is important to have the mother and father being with the baby most of the times during this, especially during this particular time. Parents of preterm babies who are discharged from the NICU have to understand the type and content of interaction required for continued development in early months of post-term life. So this is the reason why we say that we have to pay attention to the mother and the family when we are discharging a baby. It is important for them to understand that the baby which is discharged from the NICU may be alive and healthy otherwise, but for its continued development in a normal fashion, their interaction with the baby is much more important than just ensuring that it takes its medicines in time or takes its feeds in time. So interaction is important and will determine how a baby develops. Uh, so the problems that we see in follow-up infants are both related to events associated in the NICU. So whatever happened in the NICU will impact it, as well as the environment and care received after discharge. We all know that if babies are put up in, say, homes or where they're given care with other babies and are not exposed to family environment, those babies do not develop normally. And so what care that is received from the mother and father and the family is extremely important in ensuring that the baby develops normally. Ambient lighting. So as a lot of people already know, we need to ensure that there is it's more darker, and we should be able to measure at each bedside. Avoid use of ultraviolet and infrared radiation by ensuring that we use proper lamps, lens, and filters. No direct light, either electric or sunlight, should be there in the infant space, and any lighting that is outside the infant care area should be located so as to avoid any coming in the direct line of the infant's eyesight. Uh, as we saw earlier, after 28 weeks of gestation, we can do diurnal cyclic lighting, so that the baby, when the baby is asleep, we can have cycling of lights. I'll show you some pictures later on. Okay, this is even for important for caregivers. So it is important if for like when I say caregivers, it means mothers, nurses, and doctors in the NICU. So ensuring good or moderate amount of ambient light is important for their health as well. And separate procedure lighting should be available to each infant bed. So when you are doing a procedure for example, an exchange transfusion, so at that point of time, that particular area can be lighted well so that you can do your procedure. But it should be possible that other babies who are close by are not disturbed by the light from that particular area. As more and more development is possible, it is seen that in single room NICUs have a better outcome. It has been proven that having a single room NICU where a single baby and a family is there in one room and intensive care is provided in that particular room has a better developmental outcome than those babies who are cared in a common NICU, like maybe 15 babies together, etc. But it is again depends upon the resources available. Intense light, as we know, is unpleasant to the developing retina, and so we should try and prevent direct light from reaching the infant size. We can use procedure lights and adjust them appropriately so that even here we prevent a direct exposure to the infant size. Daylighting, in the sense we can ensure that good lighting happens in the day, and in the evening the lights can be automatically dimmed or reduced. At least one source of daylight should be visible from infant care areas, either from each infant room itself or from the adjacent staff work area. So in other words, in the NICU, it should be possible for everyone to understand that when it is a day or when it is night in the outside area. So not having an understanding as to what is the light outside can cause an issue. So it's important to understand that daylight also come into the NICU. Again, it is important to have preferably double glassed windows, so that sound from outside does not disturb the NICU. And we should also be able to ensure that there is no heat gain or loss. Again, after that, we should ensure that they're at least 2 feet away from any part of the infant's bed to minimize radiant heat loss. All external devices should be possible to shade the windows so that they can be either of a neutral color or opaque to reduce color distortion. So we have discussed this. So it has impact. So the visual environment of the NICU has an impact on visual acuity, color vision, okay, visual processing, and as to the size and shape of the object they are seeing, visual attention, how much they can focus on that particular person or object, discrimination of pattern, visual recognition memory, so remembering of what that object is, and visual motor regulation. So all of this, the visual environment in NICU can alter this things for the baby in the long term. So there are various things that we know: irradiance, lux, etc. We'll not go into details of that. And there are so just like lux, so there is kilos and pounds. Lux, there is something called a lux and foot candles, and you can have some kind of understanding when you read either of the two. So lux divided by 10 is equivalent to 1 foot candle. So this we have seen. So just to make it sure, avoid direct light of infant care spaces except for procedures. Avoid sensory overstimulation by light in the NICU environment. If there is a procedure that is there, then ensure that there is a individualized light exposure. Ensure that REM sleep is protected and facilitated. Ensure that there is quiet alertness and restful sleep at all points of time. Support from smooth transition from sleep to wake and vice versa. What it means is if the baby is sleeping and Suddenly, if we bring on a bright light, it might get awoken. So we don't want that. We might it is possible, and lights available where you can slowly increase the intensity of the light. Note each levels of infant level of threshold and via behavioral science, which we'll come to later. We should know what lux level of brightness is around, and how we can change it. Day-night cycling of light can be done, and it is possible. Uh, so baseline light can be between the range of 1 to 60 foot candles, and moderate light levels should be prevalent throughout the day. So even in the day, you should not have high intensity light. So this is dimmer lights at night. This is in the night. So this is in the night, again in another area. This is the St. John's NICU in Bangalore, and this is natural light in the day. So you can make out that there is hardly any difference between the lighting level. Here it is slightly darker, but because somebody is clicking the picture, you might think it is brighter. But here it is relatively showing daylight coming into the NICU from one part of the from uh, from the part which is next to this warmer, from the windows that is next to this warmer. Coming to hearing development, again, it's functional during the second trimester of pregnancy. We saw earlier that hearing develops before vision when you go in a normal sequential way. And the cochlea is functional by around 24 weeks of gestational age. And by 27 weeks, most of the fetuses respond to loud sound up to 120 decibels. And auditory discrimination in the cerebral cortex for loud pure tones can happen as early as 28 weeks of gestational age. And this is slowly developing and eventually becoming mature at 35 weeks of gestation. The fetus responds differentially to a maternal voice as compared to the unfamiliar voice. Remember that the baby in utero is listening to the mother's voice throughout its pregnancy, and when the baby comes out, it is going to remember the mother's voice. It will not remember the nurse's or the doctor's voice because they have not been in contact with the baby. Uh, Neonates with less than 2 hours postnatal experience respond selectively to the maternal voice with more activity, more motor activity as compared to unfamiliar voice. Why is this important? Because it is recommended by the WHO that all babies that are born, whether it's term, preterm, etc., preferably should be kept in skin to skin care for at least 1 hour and preferably 2 hours after birth. So this is one of the reasons, because if the baby is in skin to skin care for 1 or 2 hours after birth, it will not feel suddenly removed from the intrauterine environment. So while somebody might ask whether it's possible to do it for 25 weeker or 26 weeker, it may be difficult, but it is definitely not impossible. But it is definitely possible for maybe 34 weeker or 35 weeker if there are no other problems. So trying and maintaining skin to skin care early on is quite beneficial in many ways, but definitely under monitoring. For term babies, I think it should be a simple reason that everyone who's born term and does not have any problems should be receiving skin to skin care for at least 1 hour immediately after birth. Newborns selectively respond to speech samples carrying information whether the speaker is happy or not. And so it is possible for the baby to differentiate. So if you are going to be shouting near the NICU's bed, and if you are angry at the NICU's bed, the baby can make out that you are angry. Okay. And they prefer to hear speech as compared to similar non-speech stimulus. So in other words, they would rather prefer to hear words being spoken by people rather than hearing sounds of the monitors or the ventilator. Okay. And they can also differentiate maternal and native language from a foreign language. So this is all proven by evidence that, and this is how development kind of comes about. And coming to preterm infants who are exposed to higher frequencies of greater intensities compared with fetuses of comparable gestational age. Okay, they do not experience any of the sensory redundancy of speech and motion. Uh, Preterm babies born have shown increased incidence of sensory neural hearing loss, auditory neuropathy, spectrum disorder, and language development problems. And it is not known what is the role that is played by auditory input during the perinatal period. So, but it is known that babies who are born premature will have hearing issues. Okay, and a problematic sound environment can also affect later language acquisition in ways that we do not understand as of now. This is a slide which tells you the various noises that are there. Okay, so this is whisper would be 20 to 30 decibels, and less than 35 decibels is required for sleep. Less than 50 decibels is required for work. So this is what people have discussed. If there's light traffic or small background noise, then this is okay. But any kind of normal conversation actually is above the limits for an ICU. So people have limits of 45, 50, or 55. But in other words, even a normal conversation next to the baby's warmer or incubator is not really helpful, and we should try and do the conversations away from the neonatal bed. So heavy traffic, vacuum cleaner, or a pneumatic drill, something happening close to the ICU, can cause a lot of noise. And so dropping the head of the mattress, or closing the portal of an incubator, closing metal cabinet doors in the NICU. These are really large noises which shouldn't be there. Even bubbling in a ventilator tubing can create noise, and can be annoying. So just to give a brief overview as to any kind of noise that is going to happen is actually going to be problematic to the baby. So the idea is to have as less noise as possible to ensure that the baby is not disturbed. So this is the main thing. So how do we go about decreasing it? We'll see a bit later. As far as the heart is concerned, sounds of 60 to 90 decibels can have an increase in heart rate, and they're increased with stimuli in most mature infants. Blood pressure, people have said that it can increase, but it can also decrease, return to baseline within 5 minutes. Not very well known the effect on respiratory system. There has been mixed effects on whether oxygen saturation might increase or decrease. And so again, we are really not sure as to how it responds. And definitely it returns to baseline after the noise is removed. Sleep, of course, as I said earlier, sleep is very important, and noise does disturb sleep. There is no doubt about that. Okay, so 43% of preterm infants are negatively affected by noise, and going from a sleep state to a fussy or crying state just because of the noise that was done in the NICU. The sound levels were 5.5 decibels lower during a quiet hour when compared to control conditions. And in the quiet hour, around 84.5% of infants were in light or deep sleep compared with 33.9% in control settings. So it's quite obvious that having a quieter NICU will allow the babies to sleep much better. And sleep directly correlates with good development of the brain. Okay, noise on language and development we discussed a little bit earlier. When those babies who wore earplugs had scored 15.5 points higher than those others on what is called as the Bailey Mental Developmental Index. NICU sound level is a better independent predictor of language outcome than gestational age. So in other words, the short of it is having less noise improves language and development later on in life. Okay, so what are the various guidelines? 45 decibels is one which is recommended, but as we saw earlier, 50 decibels is what noise happens when we are just talking at a low level in the NICU. 35 decibels is when we are whispering. So you should try and get 40 to 45 decibels in the NICU, but I know it is difficult. Even if you are getting about 50 to 55 decibels in the NICU, it is quite good. Normally, if you go to NICU, the general decibel level will be 65 to 70 or 75, or maybe sometimes much more. So we are generally 20 to 25 decibels more than what we should be. Okay, so that's one. It has been seen that this is a study from St. John's where they looked at mean noise levels. So in the ventilator room, it is around 70 decibels, as I said earlier. Stable room, 61 decibels. Isolation room, 56 decibels. Extreme preterm room, 54 decibels. And preterm room, 55 decibels, 57 decibels. So if you look at a decibel level of 45 to 50 as being recommended, and as I said earlier, most of the decibel levels are more than 60. So if you get it less than 60, then it would be still good. So if you ask me 55 to 60 or 50 to 60, if you're getting, you're still doing better than most. Okay, can we reduce the noise? So what they found when they did a study and they trained everyone on nurses on how to reduce noise, they found that there was a distinct drop in decibel levels after training. But even if you look at all this thing after training, okay, if you see all of them still are above 50, though there is a significant drop in noise levels, but still the drop is uh, not, it's not dropped less than 50. um, and if you see at wherever the noise levels were low earlier, the drop has not been much. Okay, it might be statistically significant, but if you look at the decibel levels, it's hardly anything. In the noisy rooms, the drop was much more. So it's just like a person who is 150 kgs, when he does dieting, he can lose weight rapidly and get to 120 kgs. But a person who is 90 kgs, if he does dieting, will only reduce 2 or 3 kgs. He's not going to reduce much more. In the same way, if the NICU is louder, then if you do a noise reduction intervention, you can reduce noise significantly. But if the noise in the NICU is not very large, then whatever you do, you might not be able to decrease it much significantly. But still, you should try and do efforts towards it. So okay, so as I discussed earlier, engineering controls is something is when you, which is done at the building of the NICU. So decreasing sound and light levels can be best done by doing engineering controls. So you build soundproof walls, you do soundproofing of the walls, you ensure that the floor is such that when things are moved over the floor, noise is not generated, and so on and so forth. Administrative changes is, for example, you would want to say that the number of nurses working in an area can be more, so that nurses don't have to shout across each other, or you can ensure that in a particular room, instead of 6 NICU beds, you're going to have only 4 NICU beds, or you're going to ventilate, or you want to bring about, you are, suppose you have a one big room NICU and babies are ventilated in one corner, and in other corner babies are were not on ventilators are there, then you could probably break down the NICU into 4 areas, or you could ensure that ventilator areas are different from growing areas in such a way, so you can bring out some administrative changes. And behavioral changes is what we can do as doctors or nurses, and whether we can talk, we get trained, we don't talk near the warmer, etc. So in this thing about engineering controls, administrative changes and behavioral changes works across all all interventions. So this would work for traffic accidents. This would work for say elevators. This would work for NICU. This would work for adult ICU. So any change you want to make anywhere, it is seen that engineering controls can contribute to around 70% of the change. Administrative controls contribute around 20% of the change, and behavioral changes contribute to just about 10%. That is the reason when we saw in the earlier slide the noise levels did not decrease much, is because it was a behavioral change intervention which was conducted, and which cannot really contribute to a lot of change. If you really want to influence sound and light levels, you have to begin with the building and ensure that the building is done well, and so on and so forth. The lighting, so the lights that you install in the NICU can be dimmer lights. The windows that you have in the NICU can be of a certain type, and so on and so forth. So design is the most important thing. Acoustic we have discussed this to some extent. So we can have separate areas, or you can have in such a way that there is less background noise. Uh, let's skip this. Let's also skip this because we've discussed noise criteria in detail. Okay, we have discussed that we have to have 45 decibels earlier, and yeah, so we'll go next to general guidelines. There should be less glass, use only as much that is required for oxygen. So if there is more glass, then there is transmission of sound from one area to another area. There should be acoustically absorptive surfaces, so you can make the change in NICUs. Uh, there can be actually carpets. Carpets reduce the noise, but remember, if you have carpets, then your chances of infection control drop, and you can have more infections. So you have to make a trade-off whether you want to use carpets or not. Flashing fire alarms can also disturb. Tone down telephones, so your telephones which are kept at high volume can be kept at low volume, or you can have visual cues for the telephones. Isolate noise generating activities. You can have special taps for warm water, and so that when you open a tap, you can have water gushing straight away and making noise on the bassinet, or you can have water coming out slowly without making a noise on the bassinet. That amount of noise while you're washing hands also makes a difference to the noise environment in the NICU. You can have specialized ceiling, wall, and floor treatments done to reduce sound. This is again all engineering. Okay, and transmission loss and sound transmission class. So you need an acoustic engineer. So whenever if you go to a good hotel where there are big functions that are done, weddings, etc. are done, you'll find in those hotels that the sound system is very good. It is because when that particular hall was built, it was built for a wedding function or a conference, and the sound of that room is actually designed by acoustic engineers or sound engineers who come in at the time of the design of the building and ensure that sound system is perfect. Coming to premature infants, they're more vulnerable to the effects of noise exposure because of the immaturity. Uh, Again, noisy incubators, etc., can have loud jarring sounds. Uh, NICU infant stress reactions uh, have been associated with sound levels in incubator, and developmental difficulties resulting from sound processing can be seen with distractibility, hyperactivity, etc. So how do we go about sound reduction? So as I discussed earlier, we can have sound absorbing materials integrated into architectural unit design, providing minimal background noise and sound absorption in infant care spaces. Sound levels should not exceed 50 decibels, which we discussed earlier. And even transient sounds, so small sound that might happen for a few minutes, should not exceed 70 decibels at all points of time. Okay. Uh, so uh, transient sources should not exceed 70 decibels, and equipment in NICU should have noise levels of less than 40 decibels. Space and adjacent areas to NICU should not amplify sound levels. So in India, we have NICUs in the buildings where you can have some other business next to the NICU, and that business can make a lot of noise, which can affect your NICU. So this is something which we need to be aware of, and that you can't change, and or we have to have discussions to change it. And of course, everyone should be aware of what noise can do. Uh, Encourage visitors and staff to talk quietly, avoid banging leads, mute monitor alarms. Okay, have designated quiet times during the day. Monitor noise levels periodically to identify times and causes of high levels, and close incubator portholes quietly. So a lot of these things can be done by us, but as I discussed earlier, it may not really change the noise levels too much. So coming to after vision and noise, will come to what is considered as positioning. So you can see that the baby is kept flexed. This is a very small baby. You can see that the limbs are flexed, both arms and limbs, and the baby is supported. Okay. Uh, there's midline positioning of the extremities. There's containment. So the baby is contained in an area. So this the baby is contained in area, and alignment during all caregiving activities, procedures, and transports. So these nesting materials, soft blanket rolls with boundaries or swaddling is useful for decreasing the abduction of upper or the lower extremity or the startle reaction which might happen, and which can change the state of the baby from a resting stage to a alert or crying state. Uh, so positioning aids also can be gradually removed when you want to shift the baby. So it's a natural curved fetal position, symmetrical postures of trunk flexion, shoulder, hip flexion and abduction, shoulder protraction, hands being near the face, neutral alignment of ankles and hips, and neutral alignment of head and neck whenever possible. So this is something which we should try and keep doing all the time. Uh, we should handle infants in a ways that minimize stress and uncontrolled responses. As I discussed earlier, if the baby is in a sleep state, then before handling the baby, we should try and bring it to a quiet alert stage before we try and handle the baby extensively. Move infants slowly and keep them in contact with the supporting surface whenever possible. In other words, you're trying and nesting or holding the baby all the time when you're moving. So don't leave the legs unsupported uh, and try and support most of the body as far as possible. Introduce touch slowly and allow the time for the infant to respond and adjust to a change in position. Uh, Nesting should allow sufficient room for the infant to push against boundaries and to facilitate continuing development of the neuromotor and muscular skeletal system. So when you are doing this nesting, as you can see over here, it should not be totally packed so that the baby cannot move. We should leave the baby some room so the baby can move, make certain movements. Okay, swaddling, as we can see down, it is imperative that there should be boundaries without being restrictive. And the idea is to ensure that the baby has stabilized respiratory pattern and less physiologic stress. Coming towards the end of the lecture, feeding is something which we generally don't consider being part of developmental supportive care, but it's important to understand that feeding develops in a structured manner. While we give nasogastric feeds or orogastric feeds, depending upon what happens in the NICU. The baby is smaller, 26 week or 26 weeker, but as the baby matures to 32 weeks, 34 weeks, we need to slowly progress from gavage feeds to Palade feeds or Katori feeds, and later on to breastfeeding. So this kind of progression depends upon the development, and we should be constantly trying to advance the development of the baby as the gestational age improves. Non-nutritive sucking is characterized by weak suck, and it does offer advantages. Okay. Uh, it has more optimal suck pattern and should be encouraged during gavage feeds. We can try and do NNS and gavage feeds at the same time. And nutritive suck typically begins at approximately around 33 weeks. So this is the time when it is believed that when the baby is feeding, it is actually getting some nutrition from the feeding activities it is doing. Tactile stimuli, such as you can see in the picture, holding the baby does help the baby. KMC gives a lot of tactile stimuli. There has been a separate lecture on KMC and pain, so I'm not going to do into those details. Okay, so carrying in the NICU, as we know, is intrusive and stress producing, and hence it is important to ensure that the touch is gentle and warm for the baby. This is a complicated slide and towards the end, but as you can see, this is the neonatal baby. We are interested in the health, development, and well-being of the baby. There is sound design. There is the family here. Okay, there's the nurse here. There's the baby. So there are various things that we need to look at. The perception that what nurses might and doctors might be feeling as to which sounds are soothing, and a lot of context. And there is context related to telephone, building acoustics, human sounds. Then we have to look at what information is available in that particular NICU. What are the various alarms that can be muted, etc. And related to messaging, whether it's urgent and how the messaging is provided. So the picture that you see is kind of a overview of what is happening in the NICU, what various people are interacting with each other, and what are the various systems that are at play in the NICU. So behavioral organization is something which we'll look at. So something which indicates stress, autonomic, motor, state organization, attention and interaction, and self-regulation. If you remember when we saw the NCAP slides, this is what we looked at. Okay, autonomic, motor, state organization, attention and interaction, and self-regulation. So there are various behavioral cues that indicate stress. So hiccoughing, okay, cough or movement, abrupt transition to awake state. Okay, and so all of these things, if the baby is able to organize behaviorally very well, that it can maintain a balance between all this above 5 subsystems. Yawning, hiccups, sneezing, facial grimacing, squirming movements, or the salute when the baby puts the fingers over the face. This everyone would have seen. Okay, looking away from some source, jerky movements. Okay, fingers playing, tremors or clenched fist. Okay, uh, all of these indicate stress, and it is important to understand that if you see any of these cues, then we have to understand that the baby is under stress, and we need to look at what can be done to ensure that these kind of cues are not there in these babies. Calmness, if the baby is feeding and then hand to mouth indicates calmness. Hands together also indicate calmness. Sucking and smooth movements as opposed to jerky movements indicate calmness. Grasping and holding also indicate calmness. So these are the behavioral cues which indicate calmness. Putting them in a slide where you're looking at organized and disorganized. So here you have even respiration, good stable color and stable digestion as compared to tachypnea, grunting, twitching, coughing, sneezing. So this is disorganized. Okay. Then if you look at uh, robust crying, quite good self-quieting and consolability, panicked or worried alertness, eye floating, or strained or fussy crying. Okay, this is a smooth modulated posture, well modulated tone, smooth movements, while there is frantic movements, hypertonicity, or unstable tone. So if you can have an idea, so you can realize that this is a baby who is self-organizing and is probably receiving good developmental care, while this baby needs better efforts from the NICU team to ensure that the baby is well organized. Uh, as secretary of the Kangaroo Mother Care Foundation, I would like to try and uh, talk about this much more. But we already have had a talk. And this slide is here to just to make you understand that giving Kangaroo Mother Care is very useful and is probably the best developmentally supportive care that one can give. And it has immense benefits. Evidence has shown. As years pass by, we'll have more and more evidence which will show that kangaroo mother care affects even cognition of the baby. There's a separate lecture on that. We could take some time, but it's important to understand that no amount of progress in terms of ventilation or fluids or um, what do you say, uh, other things, ECMO, etc., can give you better outcomes as compared to kangaroo mother care. So if you don't have kangaroo mother care built into your system of the NICU, and if you are not giving it for a long period of time, kangaroo mother care has a dose response relationship. The more kangaroo mother care you give, the better the brain is. So if you're giving 3 hours of kangaroo mother care today in a day for a baby, you should look at 6 hours of care over the next month. If you're giving 6 hours, you should look at 12 hours. If you're giving 12 hours, you should look at 16 hours, and so on and so forth. The point is you have a target of 24 hours to achieve for every baby, and the closer you get to that target, that the baby is receiving kangaroo mother care, the better it is for the baby and as well as for everyone involved. Now, you can give 24 hours if parents and relatives take part in the kangaroo mother care. So, like everyone gives skin to skin care. So, in some NICUs, some in like few of my residents give kangaroo mother care because they feel it is good for themselves as well as for the baby. So, this is something one can even try out. So summary, brain development occurs during the stay of the NICU. I have shown you pictures which show clearly on the surface how much the brain develops from the 26th or 22nd week of gestation to 40th week of gestation. A lot of this, if the baby stays in the NICU for a long period of time, a lot of the development is happening in the NICU. We have seen how environmental stimuli can affect the development of the brain, and ensuring that the stimulation is appropriate and good proper care is given, basically try and avoid any noxious stimuli to the baby. We can play an important role in ensuring intact survival of the preterm newborns. I'm aware that this is a long lecture, but because it is going to be on YouTube, I can look at you having looking at this video for in breaks rather than looking at it continuously. And you could also go back and forth on the video to look at whatever I've spoken about. I am happy to respond to questions or either on Twitter or by email or by WhatsApp. And this is my I will I will end with my first slide to show where I can be contacted if case you want to contact me. I would like to thank Dr. Manoj from National Neurology Forum Kerala for inviting me and his entire team for doing this wonderful program for nurses, and including Karam Sad as part of the team that shares and learns from you on a regular basis. Thank you very much, and I will stop sharing my screen here and